Burns are injuries caused by direct tissue damage from exposure to either the sun, chemicals, thermal, like boiling liquids, and even electricity. Now, as you know, the skin is made of 3 layers: the epidermis, the dermis, and the subcutaneous tissue, that fatty, bubbly looking tissue. Now, after the layers of skin, we find fascia, muscle, and then bone. So in first degree or superficial burns, we have damage to the epidermis, the top layer. So we see dry with blanchable redness, meaning that when you press on the wound, the redness goes away. Now, second degree burns, called partial thickness burns, we have both the epidermis and dermis that are damaged. So the key sign to know is painful blisters, huge NCLEX tip. So write down these key words here: red, moist, and shiny fluid-filled vesicles, or basically blisters that often leak fluid. So just think 2 layers of skin for 2-degree burns, or second-degree burns. Now, third-degree burns are full-thickness burns. We have 3 layers of skin destruction: the epidermis, the dermis, and possible subcutaneous tissue, described as key terms: dry, waxy white, leathery, or even charred black color that is non-blanchable skin. Big key terms for exams. Now, 4th degree, also a full thickness burn. These are the worst burns by far, as they go through all the layers of skin down to the muscles and even the bones. A unique sign is the lack of pain, since the destruction of nerve endings from all the burn charred areas. Even though they may look similar to 3rd degree burns, these are far worse since they're far deeper. Now, for minor burns, like the 1st and 2nd degree burns, these do not typically need hospitalization and can be treated outpatient with wound care and dressing changes. Whereas major burns like 3rd degree and 4th degree, these are deadly medical emergencies requiring intensive care, which we'll cover in a moment. So first, care for minor burns. Say a client is cooking and then burns themselves, or say they spill a boiling pot of water on an extremity. So we always teach the 3 C's for pre-hospital care: cool water, cover the area, and clothing removal. So for pre-hospital care, C for cool water, key terms, is briefly soak the area. And no ice, no creams, and definitely no antibiotic ointment to open skin. The key term there is open skin. So this can lead to additional damage, and the creams, lotions, and antibiotics may interfere with the assessment from the healthcare provider. Now, the second C is cover the area with key term, clean, dry cloth. So write that down. This is done to prevent infection and more damage in the pre-hospital setting. And the last C is clothing and jewelry removal near the burn, if not adhering to the burned skin. Only the HCP should remove anything adhering to the burned skin. So please be sure to write that down. Now, Saunders mentions, the nurse instructs firefighters that in the event of a tar burn, which is the immediate action? Cooling the injury with water. Yes, that was our first C there. And the second question, for a chemical burn injury, the nurse instructs the employees that which is the first consideration in immediate care: removing all clothing, gloves, and shoes, and any undergarments. Just strip down like you're going skinny dipping. Now for Kaplan, they mention discharge teaching to a client with partial thickness burns, or 2nd degree burns, on the hand. We wrap the fingers with individual dressings. This is done to prevent tissues from sticking together and causing further damage. Now for the big mama, the pathophysiology for major burns. These can cause massive tissue damage and cellular destruction, resulting in widespread systemic inflammation that increases vascular permeability or capillary permeability. Just really fancy words for leaky blood vessels that fill up the body like a water balloon. So fluid, electrolytes, proteins, and other contents just spill over into the interstitial spaces, or the third spaces. Clients end up with severely low fluid volume intravascularly within the blood vessels, as fluid and electrolytes escape and now go into the tissues, eventually progressing into deadly hypovolemic shock. that severely low blood pressure that eventually causes death. This is why the #1 intervention for major burns in the first 24 hours, and big NCLEX tip, so write down these key terms: IV lactated ringers, or LR solution, and IV normal saline, that 0.9% sodium chloride. These two will help save lives. They are isotonic fluids, which we call isoperfect fluids, since they stay inside the veins longer than any other solution, as it closely resembles the chemical composition of human blood. Fancy words for it increases the fluid volume inside the blood vessels, increasing the blood pressure and saving your patient's life. So don't let the NCLEX trick you here. We're not administering 5% dextrose, that glucose in water, which is not an isotonic solution, and not 45% normal saline, or 0.45%. That's a hypotonic solution. Only isotonic solutions here. So write it down again: lactated ringers or normal saline. Biggest NCLEX tip. So Kaplan mentions, the nurse is caring for a client with full thickness burns covering 20% of their body. What is the priority of care after ensuring a patent airway? IV fluids. And Saunders mentions, extensive burn injury, 45% of the total body surface area. Planning for fluid resuscitation, the nurse should consider that fluid shifts to the interstitial spaces is greatest during which period of time? Between 18 and 24 hours after the injury. Yes, the key term here is before or within 24 hours of the injury. Fluid resuscitation is priority, with normal saline and lactated ringers are isotonic solutions. So please be sure to write that down. That will save a life, and it's the most tested. Now for the big signs and symptoms of major burns. These ones love to show up on exams. The key point is that in the first 24 hours, as cells burst and cellular damage occurs, the cells release potassium into the bloodstream, causing high potassium, that hyperkalemia over 5.0. So just think, potassium is priority since it pumps the heart muscles. So with high potassium, we have high pumps of the heart, leading to key terms: tall peaked T waves on the ECG monitor. Huge NCLEX tip and a big priority, because this could lead to deadly cardiac dysrhythmias, making potassium always the #1 priority. Now, some other expected findings. We see hyponatremia below 135, another big NCLEX tip, so write down that key number. Sodium is lost as fluid shifts within the blood vessels and into the tissues here. So just think, where fluids flow, electrolytes go! Now, don't let the NCLEX trick you here. Potassium is the priority here, with all those peak T waves that can lead to cardiac dysrhythmias and kill your patient. So remember, focus on any potassium higher than 5.0, because that is the priority. Now lastly, elevated H&H. So we'll see a hemoglobin that is elevated, normally between 12 and 18, and hematocrit is normally between 36 and 54%. But naturally, both of these will be elevated due to the low blood fluid volume, that hypovolemia, making the remaining blood very thick and hemoconcentrated. So that's why we see an H&H that is high when the body is dry. Now Saunders mentions severe burn injury that covers 35% of the total body surface